Hi, and welcome to the Ask Dr. Angela podcast with everyone's favorite OBGYN, Dr. Angela Jones. Have you ever been too embarrassed or shy to ask your own doctor about your, girl parts? Well, you've come to the right place to get straight answers. Feel free to ask Dr. Angela anything women's health related. Obstetrics and gynecology? She keeps it real. Pregnancy? She's been there, done that. Menopause? She'll get you through. Young or old, Dr. Angela's got you covered, girl. Now, here's Dr. Angela.
What's good, people? This is Dr. Angela, everyone's favorite OBGYN, and I would like to officially welcome you to episode number 337. Yes, you did hear that correctly, episode 337. Your girl has been doing this for a minute, and I'm so happy to be back. Today, I have the honor and pleasure of having my esteemed colleague, and I am going to say friend, yes, Dr. Suzanne Gilbert-Glantz. And we're going to just call her Dr. Suzanne just to keep it simple. But just a little background on Dr. Suzanne. She is IG famous. She received her medical degree in, I think, 1996 from USC.
Yep.
School of Medicine, and she completed her residency in obstetrics and gynecology at UCLA, Cedars-Sinai Medical Center. Dr. Suzanne is involved in women's empowerment, public education, and appears frequently as an expert in women's health and integrative medicine on TV. Dr. Suzanne is all over the place. I recently saw her on the Drew Barrymore show. She was recently on CNN. She is large and definitely in charge. And we are so super happy to have her on the show today. So welcome, my friend and colleague, Dr. Suzanne.
Hi, Dr. Angela.
Hey, girl.
It's so nice to see you and talk to you finally.
I know.
Right?
I know.
Yeah. I feel like, did we become pandemic Instagram friends or Twitter? I don't remember.
I think it was during the pandemic.
I think it was a pandemic friendship.
Yeah. Yeah. And
So
it's
great.
funny that like these things can actually translate into real life. So we are like super thrilled to have you here today. And so, one of the things that drew me to you, well, first of all, there are a lot of things that drew me to you: your boldness, your unapologeticness, your steadfastness, but really your menopause boot camp caught my attention. And I know that you just recently released the book, Menopause Boot Camp: Optimize Your Health, Empower Yourself, and Flourish as You Age. And so obviously this is what episode 337 is about. It's about menopause. And really what I wanted to talk to you about is just menopause in its entirety and why more women are not talking about this.
I don't know.
What are your thoughts on that?
Oh,
why
I have
are
a
we
lot
talking
of
about
thoughts.
this?
Well, I mean, what's interesting is that I started doing this work a while ago, right? A long time ago. And I think, as you know, we don't really get much training in menopause during our OBGYN residency. That's been discussed a lot. So I think from the medical side, there's nothing super recent, but within the last decade, surveys have been done of OBGYN program directors. So they are the people who are in charge of the residents, the specialty training.
Sure.
And they did a survey of, I think, senior residents and program directors. And there was a huge number of people coming out of their specialty training, their 4 years of training in women's health, feeling very lacking in confidence around menopause. And there's lots of stats we could throw around, but so there's a knowledge gap amongst our colleagues. And yet you come out and look, it's 4 years to do, as you know, Angela, so many different things.
Yes.
Surgery, birth, complications of all of these things. And then we're going to throw in office care, which is like as of office care, which is pretty much everything soup to nuts.
Yes.
Birth control, fertility, sexually transmitted infections, sexual health, which also gets ignored.
Yes.
Aging, And I do think some of the issue is the pay structure, because the fact is, if you need to spend more time talking about a complicated subject,
Sure.
you're not going to get compensated any differently than a 3-minute encounter that's a pap smear and here's your birth control script.
Sure.
So that's a big problem. That's a big problem. And I think anybody who ignores that in the mix is really being naive. And I think that the patients don't know this. So it's not, I don't want people to get the wrong impression. Most of your doctors are really in this for the right reasons. We trained really hard. We sacrificed a lot to do this. We really do care. But like, if you work for an employer, you've got productivity. And if you work for yourself, you've got productivity. Your office is closing if you don't make money. So this is not a philanthropy, folks. Like, this is our living. And we've got to pay off our massive debt. So I'm not going to spend the whole time on that, but I think I haven't heard that discussed at all in this conversation. And I think as we start to roll out the conversations, the New York Times is talking about it. Goop is talking about it. Oprah's talking about it.
Yeah, Oprah's talking about it.
Finally, that's helpful. But I think if people really want to see change, they're going to have to understand that there's going to have to be large policy shifts. So that's one side of it. The other side of it is cultural. As women, we are not allowed to age. We're supposed to stay young, cis, hetero, and viable sexually for men, for the patriarchy, as long as possible. So if you're not any of those things, bye-bye, you don't exist. You're threatening to the power structure because you don't need the patriarchy. Older women know better. We're not having your babies. Maybe we never were.
Right.
Now we're definitely not having your babies, and we don't care. So we're dangerous. That's why we were burned to the stake as witches.
Sure.
For real. Like, this is just fact. So women from a very early age are acculturated to be a certain way. And it's not, most people aren't super aware of it. And I don't really want to, I am pointing a finger at patriarchy, but I don't want to blame or shame people who are just subject to these cultural forces. I can tell you, I was born and raised in Beverly Hills in Los Angeles, like the epicenter of Hollywood media, all that stuff. So I really have a very deep understanding on all levels of the forces to which women are subjected, because I think at this point, everybody is subjected to the same thing. Social media is prevalent, but even when I was younger, like, it was, how you looked was just a really big thing. And women stayed blonde, and as soon as Botox and fillers came, started doing every that because they're scared that they won't exist anymore. They won't be important. They won't matter. They're afraid to talk about their age. So I'm seeing a big shift. I'm seeing that women younger, I'm 57. I'm seeing that women in their late 30s and early 40s are starting to come in to see me now. Because they're starting to talk about this. But I started doing the work, learning. I've always been interested in stuff that nobody else really wanted to talk about. I started doing the boot camps because I saw a need, because like you said, like, people didn't know. And I realized in a 5-minute encounter in the office, I don't have time to address all your questions and help you. And so I created an actual boot camp where we went through definitions, solutions, problems, came together as a community, and really supported each other and created a resource base and a community base. And the book grew out of that. The book was structured at the same as the boot camp. Even from that time, I conceived of the book. I made the book proposal. I sold the book. That was during the early part of the pandemic. And then once it was even accepted for publication, it's 2 years from the time that I sold the book to the book came out last October. And during that time, all of a sudden, everybody started talking about menopause. So it's been really, really interesting. But even so, Angela, I'm in an echo chamber a little bit. Because I realize that people still are really not understanding what their options are, scared to talk about it, ashamed. And we know that in different communities, information is reaching people at different rates. There's different taboos, there's different mores, different experiences. So, this is continuing to evolve.
One of the things that I really like that you just said is just, the variety in the range of ages that you're dealing with, because you're right. Women are now starting to talk about this in their 30s and 40s, as we go, start transitioning into perimenopause to menopause and then to postmenopause. So I think that certainly, being able to define what is perimenopause and just knowing that you can treat that, you can treat those symptoms that are associated with perimenopause, menopause, whether it's hot flashes, night sweats, dry vagina, painful
Mm-hmm.
sex,
Mm-hmm.
etc. So just for some of our listeners that are like, what are you talking about? Perimenopause and menopause are not the same thing. Postmenopause, what's that? Why don't we just go over what those definitions are in as the simplest form as we can?
Yeah. So this is what gets everybody really confused. So the reality is that menopause itself is one day. It's the day that you have reached 12 months of no period, no bleeding for no other medical reason between the ages of 45 and 55. The average age in North America is 51.4 or something like that. Although I seem to see people a little bit older now, but anyways, so that's the definition. So that means, there's no other medical reason. You haven't had chemotherapy, you haven't had your uterus removed,
Right.
you don't have a thyroid problem that's, misdiagnosed. There's no other reason under the age of 45. So from 40 to 45, if and when that happens, it's considered early menopause. And before the age of 40, it's considered premature ovarian insufficiency. So that's actually a medical diagnosis. Whereas menopause itself is not a diagnosis. It's not a pathology. It's not a disease. It's a physiologic state. I call it the puberty of midlife.
Yeah.
It's just another transition. It's pre-programmed into our bodies. The confusion is that nobody knows really exactly that that's what menopause is. And then the rest of your life is postmenopause, which is a third of your life, if not longer. So it's a very large period of time. And so to ignore this, both socially, culturally, politically, medically, psychologically, emotionally, spiritually, is ridiculous. It's a huge part of our lives. And how are we ignoring that? Again, that's participating in erasure of ourselves. And I'm not going to do that. So and I don't want other people to do that.
Right.
I think what's going on right now is great. People are talking about it. And I don't like to tell people like anything other than like, here's the terminology. Let's make sure we're addressing it. I think we're using the term menopause a lot as the transition or perimenopause. Perimenopause, peri is just a Latin term for the time around. So I joke, if you're a menopause expert like I am, everything is perimenopause, So peri is sort of fluffy and ill-defined. I don't love the term because I think that it does pathologize or turn that transition into a disease. And as I mentioned, it is not. But I think it's helpful because people will understand that there is a transition in their cycle. Their hormones are changing. Their experience of their cycle is changing. Their experience of their body, their moods, because, hormones have a huge impact on our moods, is changing. And I think it's important to acknowledge that that is real and that there are things, as you mentioned, that we can do about those things. The other big thing that I hear, and I'm sure you hear this all the time too, is people think, and our colleagues think, that you can't treat any of these things until they're fully in menopause, which is the craziest thing I've ever heard of.
Say that again. Just say that again.
Yeah. Like
you can treat these things.
Yes, you could. I don't care where you are in the transition, how old you are. You're having disruptive symptoms. Why would I not support you? That's bizarre. I find that so weird. And it's also not evidence-based.
Right.
It's not evidence-based. The data shows us that we can and should treat these symptoms. These symptoms can be early warning signs for other bigger issues. We know that we're potentially having an impact on long-term health by treating.
Yes.
People should have a choice about how they want to treat. Whether they want to do supplements and lifestyle, lifestyle is always going to be the best thing for us anyways. But also people should not be demonizing hormone therapy. It's not evil. It's fantastic for the right person.
Yeah.
So all of these things are just like these third rail topics that we're talking about now. We're touching that third rail and nobody's dying.
Right. So I don't know if you all just grasped what my friend just said, but she gave a beautiful explanation about just all of this. Perimenopause, transitioning, hormones are fluctuating, they're up, they're down. You might experience that as, your periods might become irregular, skipping months at a time, hot flashes, night sweats, vaginal dryness, heavy, light. Again, hormones are doing this.
Sleep, a lot of sleep issues, a lot of mood issues, panic and anxiety out of the blue. I've had people,
and these are very real things.
Yeah, I never had PMS really my whole life. And really in my late 30s, early 40s, I had the most horrible PMS. Like my moods were insane, so dark. I started having panic attacks. Like I'm a
Sure.
surgeon, for God's sake. I'm an
Sure.
OB. Like you
Sure.
cannot scare me. And I'm one of those
For
like calm
sure.
in the eye of the storm. You know, some of our colleagues are like
Sure.
cuckoo bananas. I
Right.
am not. I was like, "Meh."
Right.
You know, maybe inside I was, but never showed it. And oh my God. So I myself experienced a lot of these things and it was really out of body. It's so disturbing to people.
Yeah.
They feel like they're not themselves.
Yeah. And it's really difficult when you don't have someone to kind of talk about these things
Yes.
to without feeling like you're being gaslighted
Yes.
or that, it's all in your head
Or
or
it's normal. You're just getting older.
exactly,
It's normal. It's
exactly.
like, okay, well, it's expected potentially doesn't mean it's normal. If it is disruptive to you, that's not okay. Like I said, like if this is disruptive, let's try to address it.
Yeah.
And I don't know if you've had this experience, but a lot of times when I talk it through with my patients, especially in the earlier perimenopause phase,
Sure.
where things are just starting and they're like, is this happening? And when I just sort of break it down for them and I say, yeah, it's happening. And you know what? Maybe you can use your period tracker to help you
Sure.
track those symptoms. And they don't even want any solution other than that. They're like, oh, it's just because I destigmatized it. I normalized it.
Right.
I put the
Right.
power back in their hands, including letting them know, like, give this a couple of cycles and let me know what's going on. And what do you want to do? And a lot of times they're like, I don't want to do anything. Now I know 5 days before I bleed, I'm going to be a nut and I should not make
Right.
any major decisions. And I need to tell
Right.
my partner, you know what, just hold
Right.
off. And I
Right.
need to make sure I'm getting my rest. And I'm fine with that for now. Like the solution is feeling not out of control. The solution,
Empowered.
Mhm.
Empowered. And
Knowledge
knowing
is
that you're not
literally
the only
power.
one. You're not the
Exactly.
only one. And of course, because of HIPAA and all these things, we can't say, oh yeah, I just saw your girlfriend last week and she's going through the exact same thing.
But I'm starting to have a lot of people now coming in and talking. They're talking with their friends. And you know who in your practice is like the thought leader amongst her friends.
Yes.
Like she's the one who comes in first and then sends all her girlfriends. She's
Yes.
the one who's, invites everybody to brunch and talks about her hot flashes or her sexual complaints or whatever
Sure.
it is that's like, normally would be embarrassing. So it's very interesting to me to see because I think early on I was having a lot of those people and now they're sending all their friends. So in our community, people are talking about it more and getting more access, but there's always somebody every day. The other thing that I hear, which is interesting to me, and when you talk about why is there such a big knowledge gap, is our moms and our grandmas and our aunties did not talk about this with us.
Yeah.
And I got to tell you, whenever I ask a patient, have you talked to your mom about this? What was her experience like?
Right.
Often they're like, oh, she said it was nothing. It was no big deal. And I'm like, girl, what?
Right.
Like, how is it that this entire generation of women had the easiest menopause ever? I mean, some of it I think is you forget.
Sure.
So, like I remember when I talked to my mom about like after I had kids and I was like, Mom, what do I do? And she was like, I don't know. That was 30 years ago. I don't remember, So some of it is maybe they forgot. And some of it is that if it was difficult and nobody was talking about it and you hid it and you didn't experience it with anybody else, you're just glad it's over and you put it away and it didn't happen, quote unquote.
Let
I
me
don't
ask
know.
you this, Suzanne. Why do you think that so many people are afraid of hormone replacement therapy? Even our colleagues are afraid to prescribe it.
Well, our colleagues are afraid because this is not even news. Okay. So you live in the tri-state area, but everybody reads the New York Times. So here is, if you have not read the article that the New York Times Magazine published as their cover in mid-February called Women Have Been Misled About Menopause, and it's written by Susan Dominus. This is really like all day, every day. I'm like, I got to print this out and put it out for people because I just don't even want to talk about it anymore. But if you want to know the backstory on why people are afraid of hormone therapy for the last 20 plus years, this is going to explain it to you. And it's going to make you mad. Basically, the NIH conducted the largest scale study of its kind, starting in the late 90s, in order to address specifically these questions. What is hormone therapy? It was called hormone replacement therapy at the time, menopausal hormone therapy. Now we love to change terminology. We love jargoning. Yeah. That's so funny. Yeah. Anyways, whatever we're calling it, hormones. They wanted to look, well, what's the impact on women's health? Because actually at the time in North America, the predominant mode of hormone therapy, Prempro, the brand, was actually, I think, the most prescribed medication in North America, which is wild. So in the late 90s, women in menopause were on hormone therapy. They were all on hormone therapy. So they decided to conduct this study, $1 billion devoted, hundreds of thousands of people. They halted the study very suddenly in 2002, early, because they found outcomes that were negative and problematic. Well, and everybody freaked out. Everybody threw out their script. They threw out their hormones. The phones were ringing off the hook. I was a new doc. I was newly in practice, 2 years in practice.
Yes, I remember when this happened. One of my colleagues was like, I'm telling my mom to stop taking it.
And I remember specifically being in Grand Rounds, one of our, educational resources that we do in residency and that all hospitals have. Once a week, you have a featured speaker, a scientific, clinical, whatever it is. And I remember learning about how amazing estrogen was for nitrous oxide, specifically for cardiac disease. And it was like so exciting and wonderful. Like, and then like a record scratch, like at the rave, it's over. The party is over. The lights are on and everybody is fleeing for the exits. And it was really, really crazy. And immediately doctors were like, no, this isn't a good study. This study isn't looking at women. We just talked about who's transitioning, right? 40s and 50s. This women looked at women from 60 to 72, well past their menopause, many of whom already had pre-existing heart disease and other issues. So of course, they had higher rates of heart disease and stroke and heart attack and breast cancer, because those are age related. And they took everybody off the hormones, and now they're using it to say at 47 you shouldn't be on hormone therapy. It's insane. And doctors immediately were like raising their hands saying, I don't think that's what this study says. This is not a very good study. And here we are 20 plus years later. If you really want to do a deep dive, Dr. Avram Blooming, who is an oncologist here, a cancer specialist who treats breast cancer, he's in his, I think he's probably close to 80 now, here in Southern California. He wrote an incredible book with his co-author, Carol Tavris, who's a sociologist, called Estrogen Matters. And it's a takedown of the whole thing. And it's incredible. This man has spent decades really understanding the data and actually producing his own data that is counteracts this study. But he's been out in the woods. People were like, this guy's crazy. Well, it turns out he's not crazy.
Right.
So it's terrible though, because we have, 20 plus years of women who were denied medication that not only could have addressed their symptoms, as we talked about, but also may have decreased dementia, heart disease, stroke, and there's some question as to whether or not breast cancer is really impacted. In fact, there's a lot of question. Osteoporosis, we know for a fact, for sure, that is settled science. We know that estrogen decreases the risk of osteoporosis. The problem is you need to initiate these hormones, as you know, Angela, before the age of 60 and within 10 years of menopause. And now we have data showing for early menopause people. So we talked about that 45 and below, their dementia risk is decreased if they start hormone therapy within 5 years of their early menopause. Dementia is 2 to 3 times more likely to occur in women than men as they age. So do we have a generation of women with dementia that maybe wouldn't have had dementia? I don't know. It's terrible.
I know. I know it's awful. So I'm actually really happy that you mentioned breast cancer and these women with, the symptoms that are associated with the ovaries no longer producing estrogen. Postmenopausal symptoms. What are your thoughts on treating their symptoms?
It's complicated. I will say, so here, the interesting thing is that, one of the reasons I really got into menopause work was that one of my mentors as a resident is a renowned breast cancer oncologist. And when I came into practice, she started referring me a lot of her premenopausal breast cancer patients for gynecology care. And I didn't know anything about it. I had to read up and teach myself. And so I was doing all this premature ovarian insufficiency or failure, really. And these were young women who had either had surgery or chemotherapy that had rendered them now, menopausal in their 30s. And I had to figure out how to deal with their symptoms, their dry vagina and whatever. And she really supported me in doing that. So first, even though this is not what you asked, vaginal estrogen for vaginal dryness, whether it's sexual pain, discomfort in general, urinary symptoms, is not only safe, it's effective, and it's very important. And it is safe for people who have had estrogen dependent cancers. It's not absorbed systemically.
I'm going to have you say that one more time, because I can't tell you how much kickback I get
Yeah.
from oncologists.
Yeah.
I can't believe Dr. Jones gave you vaginal estrogen. Does she not know? Well, yes, she does know.
Yeah. 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 I mean, there are some cases, there are some medications that we're not supposed to give it because whatever, we don't have to get into the weeds, but in
Sure.
general, it is safe for everybody. It's safe for people who've had a stroke. It's safe for people who have
Sure.
clotting disorders. It's safe for cancer survivors. And it's not just for comfort, but I mean, for health. These are people who are going to be getting urinary tract infections,
Yes.
and they can really get sick from those things too.
Sure.
So vaginal estrogen, thank you for calling that out again. It's very, very important.
Yes.
And if someone is giving you a hard time about using it, I think you need to really get a second opinion if you have access to that, or,
Sure.
Go online, go to now they've menopause.org.
Mhm.
They will have position papers that you can print out and bring to your doc. Not everybody has access to a lot of
Sure.
doctors. Maybe this is the only oncologist they can see, but unfortunately you do have to advocate for yourself sometimes. Having said that, there are a lot of there are herbal supplements that can work pretty effectively. They're not as effective as estrogen.
Sure.
For
What
health.
are some of your favorite go-tos with
The ones
regards
that
to
I
herbal?
really
Because a lot of women likes alternative options.
Right. Absolutely. And so I'm a trained herbalist, and
Mhm.
I'm also a breast cancer survivor. So
That's why I asked you this question.
Yeah. So these are things that I really had to dig into. First, let me say that the data on these supplements and on plant-based medicine are never going to be as robust as pharma. They don't have the money, the time, or the interest, frankly, in doing
Sure.
these, large scale studies. So if you've got 200 people or 400 people in a study, you're psyched. Like, you're like, wow, that's
Sure.
amazing. So I'm always very clear with my colleagues and with my trainees and with my patients that the data is there, but it is not going to be as strong as pharma
Sure.
data. So take it for what you will.
Right.
Black cohosh, which has been much maligned because of a couple of case reports of liver failure. That doesn't mean that the plant is bad. It means that it was manufactured poorly.
Sure.
Black cohosh has been shown to be fairly effective, probably about a 50% reduction in hot flashes. There are a lot of the soy-based and what are called soy isoflavones have been shown to be helpful. Exercise, mindfulness and meditation, acupuncture, pycnogenol is another one that I really like. French marine pine bark.
Sure.
Sadly, I know that Menopause Society just put out another position paper, which I thought was really interestingly timed with a new pharma med, Veoza, saying that everything that's not pharma is not recommended.
Wow.
Now, by the way, it's not because of effectiveness. It's it's not because of safety. There's no safety issue whatsoever. It's that the effectiveness data isn't that great because of what I just said. The numbers aren't that great. I found that really bumming me. It was bumming me out, not surprising.
Sure.
So there is this new big drug that just came out that seems to have a central action. It's acting on the brain in order to impact probably the thermoregulatory center, which is where that set point, it's like your thermostat in your house is messed up, and that's why you're having the hot flash. So it seems to be pretty effective. It's pharma. It's very expensive. It's $500 a month. I can't even find it right now. I had a couple of people ask me, I can't even get it.
Wow.
And also, I mean, there's going to be side effects with that too.
Sure.
Not terrible. I think it's under 2 to 5%, but things like, all the same things you get, headaches, nausea, GI distress, blah, blah, blah. I mean, I'm not against those things. There are also off-label uses of old school antidepressants.
Yeah.
Things like Effexor can be helpful.
Yeah, the SNRIs. Absolutely.
Yes, exactly.
Absolutely.
A lot of my patients who are already on SNRIs or SSRIs, so these are your Lexapro, Celexa, Prozac, they have a quote easier menopause, well, because they're already on these medications.
Right.
But also it does help a lot with hot flashes and sleep.
Sure.
So these can be effective. Some really old school antihypertensives medications that have been used in the past for blood pressure can be helpful. So there are gabapentin.
Girl,
there
you
are
took
meds.
us back. You ran the whole gamut.
This is what I do for a living. What do you think?
I love it. But
So
let me ask you
there
this,
are a lot of
Suzanne.
things out there if you don't want to use hormones, there are.
Let me ask you this, and I'm particularly interested in this because a lot of women with regards to vaginal atrophy, don't want the estrogen.
Right.
I'm interested in your thoughts. I think I saw you talking about something. A lot of people are doing like the Mona Lisa, the vaginal laser.
Right. Yeah.
How much success are you seeing with that in your patient population? Because for me, I'm finding it's like 50-50. It's hit or miss.
Yeah, I think it depends. First of all, Mona Lisa in particular, I don't think is the best. Mona Lisa was the first. So that's the laser. There's carbon dioxide laser. Basically, we took all of these from the aesthetics people, right? So they're resurfacing or they're causing micro injury. And then the response of the tissue that is injured is to regrow, revascularize, bring more blood flow, which is going to bring more oxygen and nutrients, replenish elastin and collagen, which are going to bring that sort of tissue bounce back, essentially, stretchiness. So we know that as we age, look, we got the gels, we got the thing, the bat wings, whatever that happens in your vaginal tissue also, but the tissue also gets very, very thin. And so it doesn't respond well to touch or stretch. It can literally break.
Hence painful sex, people.
Exactly. Painful sex, but also urinary tract infection or thinking that you have a UTI and then overusing antibiotics. It's just that the tissue is burning and stinging. Look, if you have thin skin and it's out in the world and it's touched, it's going to hurt. It's going to break. It's going to cause pain. It's the same thing in the vaginal canal and the urinary tract. So the laser is okay. It's not great. The CO2 laser, the Mona Lisa, is much more superficial. The radio frequency devices and the radio frequency with microneedling, which is exactly what it sounds like, penetrates a lot deeper, and I think has a much more lasting impact and a much better impact. But I will tell you, and I tell all my patients this, if you really want this to work well, use vaginal estrogen on top of it, because it's like priming the pump. Sometimes what will happen is, and they don't need quite as much as the vaginal hormones. And a lot of times what happens is we start with the vaginal hormones and that's all they need. Is this stuff perfect? No. Is the data great? It's pretty good. It's not fantastic. Devices are never going to, again, device companies are not compelled to do the same kind of studies as pharma. So sometimes they don't do them because they don't need to. But I think that these are great alternatives for somebody who can afford it, because they are expensive and insurance does not care about your sexual life. They're not going to pay for it.
Wowzers.
Sorry.
Let me ask you this. And I know there's so much that I want to ask you because you're just doing the most. And I mean that in the best way.
Yes.
I want to go back to your menopause boot camp. And one of the things that I really like about some of the things that I've seen you doing is just, women that are perimenopausal, postmenopause, the types of exercises that we need to be doing. Cardio is not the end all be all of what we need to be doing.
Cardio is important for your heart.
Can
it's
you
not going to do anything for the rest.
The weight training, the core training, and why that's necessary.
So when I developed this program, my now former partner, who I'm still best friends with, he really influenced me. I mean, first of all, I've been a lifelong fitness person. I've always worked out. So I knew personally the benefit for myself, and I knew the data. And then I had this person in my life who that is what he did. He trained middle-aged women basically for the last 30 years. So we came up with stuff, and what you're hitting on is super duper important. Weight training, resistance training. So literally lifting heavy things. And if you've never done this before, you really need to do it with support, with a trainer or in supervision, because you can hurt yourself. You need that resistance. When you have, again, a little bit of a micro injury, you're increasing your bone density. You're building that lean body mass. You're building the bone and the muscle, because as we age, we lose muscle mass rapidly. And we need that not only to be able to, there's a concept and a measure called get up and go. And as you age, can you literally get up off a chair or off the floor and launch yourself? Because this is a predictor of longevity. And also, like, as you get older, if you're getting more fragile, you don't want to fall, you don't want to break the hip. And if you have that better bone density, you're decreasing your risk of a fracture. We know that women who have a hip fracture in their older years, their mortality skyrockets in the year following that hip fracture. So these are things we want, that core stability so that we are flexible and we don't fall. We want the bone strength so that if we do fall, we don't break something. We need that metabolically active tissue, the muscle. And we're hearing more and more and more about this. Now they're looking at how much fat is mixed into the muscle as a predictor for cardiac disease, for, dementia, for heart disease, for strokes, for diabetes. So these are really, really important, not just for like, you want to look good or your beach body,
right.
For longevity and for enjoying that longevity. for feeling good, for being vital. When we exercise and we do these things and we feel strong and we feel fit, we're bringing blood flow to our whole body. This helps us think more clearly. It helps us sleep better. Our blood sugar works better. So the weightlifting is really, really important, Angela. Cardio is great. And if you want to keep doing your spin class, do it, but it is also not weight loss. You're not going to burn fat that way. You need to have the muscles in order to burn the fat.
Yes, girl, you just drove it home.
Yeah. Yeah. And it's fun. It's
fun. It's so fun.
It's so amazing to be 57 and like lifting heavy weights, and I go back and forth. I don't do it as much. I do it as much. I've had injuries. I have to stop. I feel so, I feel literally strong. I feel like I can do anything.
Yeah.
My mood is so good afterwards.
No, I feel exactly the same way.
You're a fitness person too. Yeah.
I believe in investing in yourself.
Yes.
And so I invest in myself. I have a personal trainer. I work out with them, dedicated post call once a week. And, I work out for me.
Yes.
It gives me the energy and the stamina to be able to do what I need to do.
Yeah.
It elevates my mood. I can't speak highly enough. And frankly, I'm one of these lead by example folks. I can't ask you to do something that I myself am not willing to do. So it helps me to hold my own self accountable.
Yeah.
As
so
well.
important. So important.
For sure.
Yeah.
So, I mean, you have been really a wealth of information and knowledge. I mean, frankly, Suzanne, I could talk to you for hours because I really appreciate the ease of conversation, and you just break it down in such a way that anyone can understand. And really, one of the things that I always tell women is don't leave the room without a complete understanding of what's going on. And certainly if your physician or practitioner isn't, explaining things in such a manner, either you can ask for clarification or find someone else, frankly, who, is able to break things down in a way that you will understand. Menopause and perimenopause and postmenopause are vastly important topics in women's lives. And certainly we're seeing more and more women in this stage of life. I mean, every day I'm seeing a ton of patients that are in this stage of their life. So I'm really thrilled to know that there are people like you that are comfortable addressing it and speaking about it. Because frankly, women want to feel empowered. They want to be acknowledged, and they need to be given information, solid information about what's going on and, the various choices that they have. So I just want to thank you for doing what you're doing and to tell you to keep doing what you're doing. Because your work, sister,
thank you.
my sister from another mister.
Yes,
is
totally.
Phenomenal. It's phenomenal.
Thank you. It means a lot. And thank you for introducing me to your audience and giving me the opportunity to share, because it is really what I love doing. I love teaching. I do want to say one thing. I think if you're feeling frustrated, it is, you touched on it. There's a lot of noise out there, and it can be very, very difficult to understand what is legit information and what is not. One of the things that my book addresses is how to advocate for yourself with your physician. Sure. And not in a combative way. I don't think that's effective. But I think that's something that I really felt strongly about. And I've actually had people give me feedback and say, oh my God, I brought in my little advocacy worksheet and it worked so great. My doctor was not defensive. She really appreciated that I had focused on what I needed and wanted from her, and she was more able to give me what I needed. So I think I feel very strongly about reparative justice on all levels. And that is my little nod to it in the book. So I want to point that out, that I want the book is really meant to be a roadmap and a toolkit.
Sure. So why don't you do this for me before we sign off of this? Why don't you tell everyone where they can get your book? Because I'm going to get your book.
Well, I mean, you can get it anywhere. It was published by HarperCollins. So if you just Google it, you can either go to my website, and then I have a link to, Barnes and Noble, bookshop.org, Amazon if you must, whatever. So you can just, Google Menopause Bootcamp, or if you go to my website, then you will find everything. So that's the Dr. Suzanne, THEDRSUZANNE.com. And then you've got all my socials. I'm really active on Instagram, TikTok, Facebook, Menopause Bootcamp, which is going to have its own spin-off website probably by the end of the summer. And very excitingly, I have created a certification program so that people who want to be their own menopause bootcamp trainers and run their own menopause boot camps will be able to do so with my blessing and training. When I wrote the book and started doing the boot camps, I never conceived of it as something that I was going to do alone. I sort of touched on it, but like, I don't feel that it's appropriate for me to step into everybody's community. I don't understand your community like you understand your community. And I think it's really, I see this as a grassroots movement of women taking back their time, taking back their time, their lives, their health, and creating community for one another. And the planet really needs us. The planet needs women with experience and confidence, and we need each other. So I'm excited about that. That's the next thing happening.
That's a really big thing happening, and I'm excited to witness that. But I'm going to want a signed copy. So I'm going to have to buy it and then mail it to you, or how do I make that happen?
I'm not, it's not like I'm never come back to New York. So I'm going to make you come have lunch with me next time I'm there.
Please hold me to that. The next time you're on the East Coast, I'm in New Jersey, for crying out loud, like a stone's throw away.
I know. We're going to figure it out. And then I'm going to bring you, you're going to bring your book and I'm going to sign it.
So we're going to do this, people. First of all, thank you so much to my esteemed colleague and friend, Dr. Suzanne, for sharing your wealth of knowledge on all things menopause. We appreciate you. We love you. We're so grateful for the work that you are doing. I'd like for you guys to just continue to follow. You know where I am, www.askdrangela.com. That's www.askdrangela.com. I'm all over social media. If you just go to my website, you can follow me there. Instagram, Twitter, Facebook, TikTok. I'm everywhere. In closing, I would like to leave you with this thought from Life's Little Instruction Book. And it just kind of helps me to keep things in perspective and what is most important in life. It's actually lesson 304. And it says, judge your success by the degree that you are enjoying peace, health, and love. Until next time, be well, be healthy. We'll see you soon on episode 338. Until next time, goodbye.
Thank you for listening to the Ask Dr. Angela podcast. For more information on women's health and the show notes for this episode, please visit Dr. Angela at www.askdrangela.com. While you're there, don't forget to leave your own message for Dr. Angela. See you soon. All of the information provided and discussed in this podcast is for educational and informational purposes only and should not take the place of consulting a physician. This podcast is not intended to diagnose, treat, or cure any disease or illness and does not and should not replace treatment from a medical professional. Listening to and participating in this podcast does not create a doctor-patient relationship between you and Dr. Angela Jones. If you need medical advice or assistance, you should consult a physician. Listening to and participating in this podcast is subject to the terms and conditions posted at askdrangela.com/terms.